Welcome to the Catalysts podcast. I'm your host, Patrick Morley. Breast cancer is the most common cancer in Canadian women, with 1 in 8 women facing a diagnosis in their lifetime. And breast cancer is a complex foe shaped by biology, lifestyle, made difficult by invasive treatments and diagnostic techniques. But thanks to the work of today's guest, Dr. Lohmann, this complexity and difficulty is being met head-on. She's uncovering how obesity, our metabolism, social inequality, and even a common diabetes drug are working to improve treatment outcomes while lowering the risk of recurrence. Truly groundbreaking work. Welcome to the Catalysts.
Thank you for having me. It's a pleasure.
Yeah, thanks for joining us today. Before we get into your fascinating research, let's talk about breast cancer in general. Like I mentioned in the intro, it is the most common cancer in women. And I'm kind of curious about what has inspired you to dedicate your life to studying and understanding breast cancer.
Yeah, well, thank you for having me. It's a great initiative. So I have physicians in my family, like my grandfather was a psychiatrist, 2 cardiologists as well. But in medical school, during medical school, I thought I got really interested in female cancers and treatment. And as a female physician, how can I listen and provide compassionate care to my patient? I also got inspired by a friend who had, her mother had breast cancer and died suddenly decades ago. And also grandfather who had cancer. So I got really curious about cancer treatment in general. And right now I treat breast cancer as well as gynecological malignancies like ovarian cancer, endometrial cancer, and cervical cancer. So these are my areas of expertise, female cancers in general. I provide systemic treatment, that's how we call, for women who would benefit for systemic treatment to prevent recurrence or treat in case of advanced, in the advanced setting.
Right. So you come from a long line of doctors and...
Yeah, at least I would say 3. My grandfather was a psychiatrist. I have an uncle who is a cardiologist and a cousin. Yeah. She's a cardiologist as well, but I changed a little bit the focus. I think also during medical school, the research was quite intriguing, and so I got really interested in this field.
Yeah, most cancer researchers tend to have personal stories, and I think it's fair to say that anyone listening to this podcast knows someone or has been touched by breast cancer, whether it's a mother, a sister, a friend. Is that something that you think about when you're, getting up in the morning and tackling your day's research? Do you think of that prevalence? 1 in 8 is a lot, right?
It is a lot. So it's something that I think about. A personal friend, a couple 10 years ago, was diagnosed with breast cancer as well. My cousin was recently diagnosed with breast cancer. So it's there. It's all the time, right? A friend was diagnosed with breast cancer, another friend as well. So it's very common. I think the treatment has improved significantly if you compare to decades ago.
Yeah, they spiked, I think, in about 1986. Breast cancer diagnoses kind of spiked, and then have they leveled off a little bit?
Yeah. So what you see, I was mentioning about the treatment. The treatment has improved significantly. The incidence is still there. 1 in 8 women are diagnosed with breast cancer, so it's a lot. And as the population is aging, we'll see more, right? So more cases. So 2 factors, I would say: obesity epidemic, that's how we see right now, and aging. This is also one of the reasons, like, for example, endometrial cancer, which is the lining of the uterus cancer, is the incidence and the mortality they are increasing.
Right. That's it's probably a good time then to get into the obesity connection to breast cancer.
Sure.
I know that much of your research is focused on the role that obesity and metabolic health
Yeah.
play in cancer. Why is this connection there? I think listeners are fascinated by this link between obesity and their chances of getting breast cancer.
Sure. The association is quite complex, but there are some factors. For example, the excess of fatty tissue can lead to increase in some hormones like estrogens.
Okay.
And
so fat will increase
the risk of our fat tissue is quite metabolic active.
Right. Okay.
So we can have a higher levels of hormones that may be linked to breast cancer. So we have more what we call insulin resistance, and also increase of some factors. Insulin like growth factor can lead to also increase or proliferation of cancer cells.
Right.
So multiple factors. Also inflammation.
Right.
So chronic inflammation. So obesity is associated with chronic inflammation.
Right.
We don't know with the association between obesity and cancer. There's a causal association, but we know there is an association, a link.
Right.
We say in epidemiology there is an association, but we don't know it's causal.
Right.
If it's really the reason we have an increased incidence, but we see there is an association, a link.
Right.
Between obesity and some cancers.
So you know that fat kind of can increase a hormone output that might, at this point, increase. Would it be fair to say it can activate cancer cells?
Exactly, the proliferation. It can provide unhealthy, or for the cancer, a healthy environment, right? That can lead to cancer proliferation.
Yeah.
So, for example, if you want to have some data, so obesity is associated with increased risk of postmenopausal breast cancer.
Okay.
Obesity is associated with increased risk of liver cancer. Also endometrium that I comment, the lining of the uterus, ovarian cancer. There's some data in multiple myeloma, which is a hematological malignancy. So several prostate cancer in men. So there is an increased risk of having developing cancer in the future. Mm-hmm.
And I think, on top of that, there seems to be an obesity epidemic in Western culture. Now, I think it's important and fascinating to me that there's this, uptick in obesity, which is going to lead to more negative health outcomes.
Yeah.
But the actual mechanisms at work that are causing this obesity epidemic are quite fascinating and also very complex.
Mm-hmm.
What are some of the things that you think are happening in Western society that is causing this kind of obesity epidemic? What's going on?
Multifactorial. So I would say lifestyle, lack of exercise, processed food, which increased in the last decades. So unhealthy lifestyle. If you think about women and young women, in general, they exercise as a teenagers or young children, and they go to university. If they go for college, for example, there are exercise programs, but then they have children, they gain weight and sometimes can't lose all the weight, and life gets busier. So I think there are multiple factors, also menopause, that may have increased in weight as well. So our lifestyle in general doesn't favor women's health.
Right.
And also the type of food that we eat, lots of sugars and everywhere, unhealthy food, processed food as well.
Yeah. I think every busy family will know, or busy single mother or single father will know, that it's very easy to put in a pizza into the oven. It's arguably cheaper
for sure.
With food inflation.
Yeah.
Going to McDonald's. So it seems like there is something definitely happening in modern society that is increasing this obesity
Yeah, and
Yeah.
cost of living as well. As you mentioned, is more expensive to buy fruits and vegetable
Yes.
than fast food,
Right. So it's
right?
like a perfect storm, it sounds, in a lot of ways,
Exactly.
right?
And if you see the portions as well, when we buy something like French fries, it's like big portions, right? We don't need all those calories for sure.
Right.
So there are lots of things related to obesity, I would say, and we can say there's obesity epidemic. I have some data, for example, that I thought was very interesting in Canada from 20 to around 2000, obese based on data from self-reported data showed obesity increase from 20% to 28%. So if you compare 2000 to 2020 the dates,
Right.
so it's quite huge, like 30% of population to be obese. It's a very impressive, unfortunate number
Yeah.
to see. Other factors as well, I would say lack of access to healthcare or family doctors
Right.
as
Yeah.
well. We don't have that data, but we know if you have a family doctor, also have a better
Yeah.
health for sure.
For sure. And we
Yeah.
are, just to add another crisis to our
Exact-
conversation, do have a
Unfortunately,
family
yeah.
doctor crisis. I think almost 2 million Ontario residents
Exactly.
don't have a family doctor.
And there's some data actually when researchers here from Western show women without family docs may present with more advanced breast cancer because it's
Right.
more difficult to have access to tests. They need to go to a walk-in clinic, or maybe they don't have a physician telling them, "Oh, we need to go for your mammogram screen."
Right.
Right. So
Yeah.
there are a couple factors
Yeah.
there as well.
So just to pile on to this crisis,
Mhm.
we'll get to the hope
Yeah,
very soon.
exactly.
But
Yeah.
there are other, I think, fascinating and quite shocking statistics about, if you're a woman, a racialized woman, I think a Black woman in Canada aged 40 to 49 has a 40% higher mortality rate, according to the
Yeah.
Canadian Cancer Society. Indigenous and Métis women also have higher mortality rates. Poorer racialized women, they have delays in diagnosis,
Yeah.
less screening,
Yeah.
poor survival rates. So we really see this as a massive social problem, right?
It is definitely social problem disparities, and it's probably access to care, healthcare, and they probably are diagnosed at more advanced staging.
Yeah.
And if you think about most of breast cancers, 75% of breast cancers, they are hormone receptor positive. So there are different types of breast cancer patients who are diagnosed with, let's say, early stage breast cancer. If they have hormone receptor positive, they need to take medication after the diagnosis. That
Right.
medication might not be covered.
Right.
Right.
Okay.
So that is another issue. If you have private insurance, you maybe have access to that drug, or Trillium. There are other programs as well, but sometimes you don't fit into that criteria, so you need to pay. So there is a cost as well. You stop working.
Yeah.
To have your treatment. If
Yeah,
you need
definitely.
chemotherapy, there is a financial impact, a burden as well. Who is going to look after your children if you're young? Right. So there is a big impact, financial impact, mental health impact.
Yeah.
As well. And sometimes it's very hard to go back to work to do the same activity used to do.
Yeah.
So several factors.
Yeah.
Yeah.
That's a big question. Do you have any ideas to how to solve this very complex puzzle?
Mm-hmm.
Education, new policies. Do you
Yeah.
have? And this is maybe a more personal
Yeah,
question.
because it's not my area of expertise, but definitely we definitely need more family doctors for sure. I think awareness. October is awareness month for
breast cancer
awareness. So access to mammograms, now screening moved to 40 years old. It's a good initiative.
Yeah.
Women can be self-referred and have screening. I think awareness is very, very important. And make sure the access, if it's not by screening, if they detect a lump, which is the most common way to detect it, could be through screening, which is ideal because the tumor size will be smaller. But if they if they find a lump, they would then be able to seek medical attention, have their imagings, their biopsies, whatever needs to be done quickly.
Yes.
Right? You imagine in rural areas, remote areas, that might be a challenge as well. And I think also support during treatment. So, for example, Southwestern Ontario, we cover a very large area. So even patients from Wingham, they come here to see a medical oncologist. So really access to treatment close home, which we have right now, but they still need to travel 2 hours to come and see me, which is a lot, right? So there is a financial burden. There is someone else driving them here to see us. So there are multiple factors depending if you are in a city or in a rural area. But I think to solve this issue, I think there are a couple of things that need to be done: awareness, education, also financial probably support, and family doctors, access to treatment quickly, and imaging as well.
Right. It does sound a lot like the family doctor is the conduit to almost everything, right? Early detection, early screening, right? Early treatment. Everything flows through that primary caregiver, right?
The referrals, so family doctor sends a referral, or at least encourage the women to have screening mammograms, which is fantastic. And they are diagnosed with early stage breast cancer, for example. Then a referral is sent. Patients, they have support close home as well, which is important. Even if they need to travel for oncological treatment. So it is very important because there are other, like hypertension, that needs to be treated. Sometimes there are other diseases that need to be addressed.
Right, yeah. Okay.
So family doctors are essential. And I think awareness as well about the screening, the new age, around the 40s. Also, if someone has a strong family history of breast cancer, we have a great program in Ontario that women can be referred to a genetic counselor and see if they can have genetic testing. But this is the minority of breast cancer cases. Most of the cases are not linked to any gene, any genetics. We say most of the cases are multifactorial. We don't fully understand the reason. So there are a couple of things that need to be done.
So it sounds like, if you're a woman around 40 years old, self-advocacy, education, knowing what you need to do becomes very important. So I guess the call here is to urge, women to take control of
For sure.
of their health and their bodies, especially at that age, to get into the screening process, right?
Yeah, and also try to have a healthy lifestyle if possible. It is very hard in our society right now, but try to keep the normal weight if possible, healthy diet, avoid smoking, alcohol. This is all. We need to keep talking about this, but it's important. But we also need to think about obesity as a disease, right? It's not only, there are other metabolic factors, right? It's not easy to lose weight and to keep weight. And women gain weight through life, as I explained. After children, after menopause, there is intense work at home, outside home. So it's very hard on women, I believe. So also, if you have a family doctor, you can discuss these factors as well, like what are their waiting, the programs that can support health, like community centers. That can support physical activity or access to dietitian, which can be a problem. So healthy lifestyle interventions, like
very important.
That's what I would say.
No, it seems we have an uphill battle, but if we get this awareness out, people can start making changes.
I'll give you an example. Like if you walk with your kids to school, it's better than if you drive, right? So little changes. If you have a more walkable, like city, for example,
for sure,
better
absolutely.
than only driving.
No, there's
example
lots.
Is London.
No, there's lots of things. I think we really need to sort of hold policymakers, politicians, city planners accountable for creating places where we can be healthier than where we are now. I mean, you really don't have to leave your house in 2025 whatsoever, right? You have TV, you have Uber Eats delivering food, you can get your groceries delivered. So it's a really uphill battle, I think.
Yeah, it is. Yeah, parks, community center.
Yeah. Rapid development is happening fast, so maybe long-term planning isn't quite happening. Yeah. It sounds like, you talk a lot about the metabolic associations with breast cancer, and it seems like the metabolism is again having a moment in 2025 with drugs such as Ozempic, the metabolic drug that people are taking to lose weight. Now, you, I think in 2021 received a nice grant to explore metformin, which some people might know is a pretty common diabetes drug. We don't have to get too deep into that association, but what are these drugs doing that are helping or have potential to help with breast cancer? What is that relationship?
Yeah, I'll explain and clarify. Actually, there is a large study conducted by Dr. Pamela Goodwin, who is just actually was my PhD supervisor, with metformin versus no metformin placebo.
Okay.
After 5 years. The overall study, it was a Canadian study conducted by Canadian Cancer Trials Group, CCTG, in Kingston, but is a international study that did not show metformin, which is used for diabetes, didn't show a reduction in breast cancer recurrence. So women with early stage breast cancer received metformin versus no metformin after their regular treatment. The overall study didn't show an impact on breast cancer recurrence, only in one subgroup called HER2 positive. This needs to be addressed in another trial. But it gave us information about the metabolic status of women. It provided important information, that study. So there are some sub-studies that I participate. One important data that we presented now at the American Society of Clinical Oncology annual meeting relate to that study. Then we moved to other drugs is the patterns of recurrence. So women who are diagnosed with early stage breast cancer, what happened before 5 years and after 5 years. And this is important in hormone receptor positive breast cancer, which is the most common type of breast cancer. As I mentioned, the tablets, that women need to take tablets after anti-estrogen treatment after breast cancer diagnosis. So what we see that in hormone receptor positive breast cancer, these patterns, there is a constant risk of recurrence, breast cancer recurrence. So it doesn't stop after 5 years. So there's something important. So women need to know about it.
And 5 years, is just, that's kind of like the time frame where you can maybe be deemed cancer free.
Yeah, for some cancers, that's what there's this magic number of 5 years. So so that's why we're trying to understand. For this subtype called hormone receptor positive breast cancer, actually the recurrence is still occur after 5 years. We call late recurrence. And after 5 years. But one thing that is important to say, we notice that other cancers can be found. So if someone had breast cancer in the past and they have hormone receptor positive breast cancer, there's still a risk after 5 years to have a recurrence, unfortunately. We're improving treatments to prevent the recurrence. However, if someone shows up, let's say, with suspicion lesions in the bone or the liver, it could be another cancer. So the study provides some awareness that for clinicians and patients. And in other cancer subtypes, for example, we call triple negative, which is an aggressive subtype, that is estrogen receptor negative, progesterone receptor negative, and HER2, which is a growth factor negative. So we call triple negative. And another subtype called HER2 positive, which is a growth factor. Basically, 3 subtypes of breast cancer. The other 2 subtypes, we see that most of the events after 5 years are actually other cancers.
Right.
So although women had breast cancer in the past, you need to be aware there is still a risk of other cancers.
Right. What do you think, as a scientist, you're curious, always curious, curious. What do you think are we on the verge of finding a really strong link between the metabolism and the cancer? Are we close there, or has that been established?
Yeah, and I didn't answer the other questions. Yeah. So I think there is this complex association between metabolism, obesity, cancer, but I think right now we understand more about this complex association than in the last 30 years, for example.
Yeah.
What we don't fully understand is for some cancers, if there is an association between if you lose weight, someone who is diagnosed with breast cancer and is overweight or obese, if they lose weight, we know it's important for overall health, right? To reduce the risk of cardiovascular disease or risk of developing other cancers. So what we don't fully understand is that if you lose weight after cancer diagnosis, if you reduce the risk of cancer from coming back, that cancer that was diagnosed.
Right.
So there are several ongoing studies. There are ongoing studies that trying to address this. And for example, in breast cancer, one study called Be Well study.
Okay.
That a group of women, we participate as well here in London and Canada as well. Trying to understand if women lose weight, they participate in a more intense program, weight loss program, as opposed to just educational materials, what we do right now. If weight loss is related to lower risk of recurrence, the cancer that the patient had from coming back.
Right.
So it's a different question.
Yeah. And that's really sounds like a really important question to answer. Yeah, definitely.
Then there is a role for these drugs that you comment on. So that study, the Be Well, it didn't include any medication.
Right.
No new medications for that. It was more coach, was a program like a lifestyle intervention. The coach would call the patients and prescribe exercise. And diet, dietitian as well.
Yeah.
So different. So we don't have that data. One thing that is interesting to comment is there's a Canadian study was recently published. New England Journal of Medicine was an important journal.
Yeah, big important.
Yeah, so that showed the reduction exercise after colon cancer.
Yeah.
Reduce the risk of colon cancer recurrence. So patients with early stage colon cancer who participate in that exercise program, regardless of their weight, they saw a lower risk of colorectal recurrence. We know for overall health, it's good.
Right.
But the question is, can we reduce the risk of recurrence?
Right.
And yeah, definitely we saw so many changes, right, recent with new medications. We don't have a study right now that provides that medication and see if there is any changes in cancer outcome in breast cancer right now, a large trial. We don't. But what I think is very interesting, there's a recent meta-analysis showing that patients who receive these drugs, you mentioned Ozempic, for example, so our audience will know. Our audience will know what we're talking about, GLP-1. There is a lower risk of cancers, developed cancer. We are talking about then incidence here.
Right.
My focus of research is more about cancer outcomes, but that is a very important data.
Yeah.
This mini-series is in support of the J. Allen Taylor International Prize in Medicine.
In 10 years, are you able to to predict a little bit of the future, or your hopes for the future with these drugs and with exercise, with the knowledge we have with obesity and breast cancer? Do you think we'll
I think there are a couple of things. I think awareness is very important. The amount of food we eat, like we're talking about big portions that I comment, like sometimes
yeah
very big. Like we need to be aware of that.
Yeah.
But in terms of obesity, so I'm talking about awareness, like the society needs to be more welcoming,
Yes.
right?
Yeah.
Because we are going to a different direction. But in terms of knowledge and data, I think we'll definitely have more information. I think it's something very inspiring to say and hopeful to say is that breast cancer outcomes have improved.
Yes, they have.
We're talking about, we don't say cure, but I tell my patients we want to keep the cancer away and stay away for early stage breast cancer. And also more treatment for patients who have advanced disease, which means the disease has already spread.
Right.
So the outcomes have significantly improved in early stage and in advanced stage, and that is very important.
Yeah. Well, there's the hope. The hope.
Yeah, oh, for sure.
Right.
It's,
In
yeah.
2025, the diagnosis is still awful and difficult to deal with,
Okay.
but you can give your patients hope that maybe you couldn't have before, which is wonderful.
Exactly. Yeah. I think what we may change in the future is the last decades we add more treatments,
Right.
which is great, reduce the risk of cancer recurrence, but maybe the future will be also on de-escalation. How can we reduce treatment?
Right.
How can we identify blood tests or other markers that will tell me, okay, not everybody needs this medication, not all women or men diagnosed with breast cancer need this treatment. So that may improve quality of life.
Yes.
Yeah, and we don't need to provide unnecessary treatment.
Right.
So I think that's how we're going to move.
Yeah, great.
Forward.
I know translational research is really important to you and to the work at Schulich. Can you tell me about the liquid biopsies and how that is sort of revolutionizing how we're diagnosing breast cancer?
Yeah, so it is also a hot topic. We talk about GLP-1, but also liquid biopsy seems to be a hot topic. So these liquid biopsies are blood tests, in general blood tests, that we detect pieces of tumor DNA, we call circulating tumor DNA. It could be circulating tumor DNA, circulating tumor cells.
In the blood.
In general, in the blood.
Yeah.
Okay. So these tests, we call biomarkers, these tests or liquid biopsy, can be used in different areas. If someone has an advanced cancer and the liquid biopsy, for example, circulating tumor DNA, pieces of tumor DNA in the blood, can be detected, and we found a specific protein we call mutation, then patients are eligible for specific treatments.
Okay.
Which is very important because then we say, oh, there is a clinical utility, which means that protein that was detected in the blood means that that patient would benefit from specific treatment,
right,
which can improve outcomes. So that's how we are right now in terms of breast cancer treatment. We say there is clinical utility to use this liquid biopsy, which means we would change treatment if we detect this mutation, this positive liquid biopsy test in the advanced setting. If we move to the early stage, that's your question. So what we are studying now, it's called CLEAR study, is a Canadian breast cancer study in the early stage. We're trying to understand if women who are diagnosed more than 5 years, So I'm trying to address the late recurrence that I mentioned earlier. Women with hormone receptor positive breast cancer, which is the most common subtype.
Right.
If we can identify these markers after 5 years before and identify these tests, liquid biopsy in the blood, before they develop clinical recurrence. Because right now we follow the patient, but we don't have evidence that if you have CT scans or other tests, they can detect the cancer earlier.
Right.
We have tests with x-rays, ultrasounds that didn't show any difference in outcome. So right now we follow patients who had breast cancer, finish their treatment, early stage breast cancer with mammograms, physical examination, we address their symptoms. But if we don't have a test that can predict those who will develop cancer in the future, and a good test that will prevent recurrence before they have symptoms, which is incurable. There are tests in American companies, several medical companies, that show that we can detect the test can be positive, circulating tumor DNA before the recurrence. But this timing is not a long lead time that we call, like 1 year, 1.5 years.
Okay.
So more needs to be done. And so right now, the use of liquid biopsy in breast cancer, I would say, ideally, the clinical utility right now is to change treatment in advanced setting. But there are several studies, including the Canadian study that I mentioned, CLEAR study. That's a collaboration with other sites. 400 women we are following. And we don't have enough data to show that we need to test women who are diagnosed with breast cancer right now. So we are not recommending this, but it's a very exciting area. Because if we could detect, if a test could detect, predict recurrence in the future, we can maybe intervene.
100%, right.
And prevent treatments in those who don't need. Right?
Yeah.
So that is the portion that the intervention that is missing right now. And we don't know if those who test negative, we can stop treatment, or those who test positive, what are the treatments that can be offered. And it can cause a lot of anxiety as well if you were tested with, if you have received a test or a liquid biopsy test showed that your results are positive.
Yes,
what do you do with
exactly.
that?
Yeah, that was going to be kind of my next question is what, as a clinician and someone who's passionate about this, what do you do in that situation, or what would you do? How would you communicate that? So
right now, we do not recommend, there's not a recommendation for Canadian Cancer Society or American societies in terms of recommending these tests. But the patients, they know, breast cancer, patients who are diagnosed with breast cancer, they are very active. There are lots of advocacy groups.
Right, yes.
So they are aware. So I had patients who come to me and ask for the test. So we need to sit down and have counseling. Like I have to explain if the test comes back negative. First, is not covered, right? Because there's no indication right now in the early stage setting.
So they have to pay out of
they have
pocket.
to pay, is expensive. And what do we do with results? That's the key question.
Yes.
And have patients, the results came back negative. So I strongly recommend them to continue on the tablets if they're taking the tablets, the anti-estrogen treatment.
Yeah.
And if it comes back positive, then we have to sit down, discuss, maybe do CT scans and see if they have already recurrences, or seek for clinical trials, like try to find clinical trials.
Yeah. This is definitely something that we talked about with Dr. David Palma about the new cancer patient, right, who comes in with the knowledge. I'm sure you've seen this. Is that something that you embrace and appreciate?
Oh, for sure.
Educated patients, or can it be, are you being inundated with false information or misinformation? How are you working that balance?
What I tell patients, don't Google because
Don't Google.
Don't Google. I say don't Google because go to the best websites. So breast cancer Canada, breast cancer societies, American Society of Clinical Oncology. So they're very serious websites
Yes.
and that can support patients. Cancer Care Ontario as well. So we kind of try to explain, because if you Google, you may receive information about some treatments they are not recommended,
Right. Yeah.
like alternative treatments.
For sure. Yeah.
There are very good alternative treatments out there, acupuncture for hot flashes or for pain, ginger for chemotherapy. So there are actually randomized trials showing that they benefit.
Right.
The problem when patients sometimes tell me, oh, I want to have this specific treatment during my chemotherapy, we don't have the data. Maybe there's like some toxicities that we want to avoid. So I think it's very good when the patients, they ask.
Yeah, definitely.
Yeah. And also we learn a lot. So a recent patient came to me and asked, oh, I'm interested in that clinical trial. I knew the clinical trial was coming, but I didn't know was open already. So she came to me,
Right.
giving information in another site, for example. Because clinical trials, they open, close all the time here and in other sites.
Yeah.
So it's very interesting to know. And I think I'm also very grateful for the patients. They are so active. They talk to each other. They try to support our cancer center, for example, here. They, even if they don't have funds, some of them wants to give it back, like donors, but sometimes just, which is not just, but it's their time as well. They want to be volunteers. So they're very proactive, I would say. Very interesting community.
Great.
Yeah.
I think that the last thing I'd like to ask you is, you mentioned there's a community almost of breast cancer survivors, also people still in treatment. How do you feel to be part of this community of, after treatment breast cancer survivors? This because that's your life's work, is focusing on reoccurrence and, again, life after breast cancer. Yeah. How does that make you feel when you're surrounded by women who have survived?
Yeah. So in the past, our concern was more about we want to reduce the risk of recurrence, but we are reaching to a point is that we want to make sure patients, they have a lower risk of recurrence for early stage breast cancer, but also they have good quality of life. So it's a big impact now. We need to make sure they might not go back to the same level before treatment, but we want to make sure they have life, they can thrive, they can work, they go back to their families. So it's very important. So I think counseling is important. I think I always try to talk about healthy lifestyle, even if it's 5 minutes. I talk about exercise, I talk about healthy lifestyle. And some patients, they listened, and some patients, they next time, oh, she's coming back again, talking about the same thing again. So I try to talk about healthy lifestyle, healthy diet, balanced diet, and exercise, resistance training. Elderly patients, I talk about where are your weights, and try to be active, find a community center. And we see big changes, so it's important. And this can have an impact on their quality of life, like hot flashes. You feel better when you exercise, right? And it can reduce the risk of cardiovascular disease.
Yeah, definitely.
Because most of women will not develop a recurrence. And I also try to point out that there are other factors can impact your life, like cardiovascular disease, risk of stroke, heart attack after cancer. So I think that's my focus on survivorship. And we'll have more information on survivorship based on the studies that I mentioned that we are conducting. How exercise or how quality of life changes over time in our Canadian population. So it will be data that is coming up in the next year or so
from
our studies. and also how this test can help women to predict recurrence in the future.
Great, yeah. Well, I'll definitely be hearing your voice when I need to go out for a walk, go out for exercise. You can, side hustle as a bit of a life coach.
Are we going to record my voice for myself as well? Like, you need to go.
Yeah. No, it is all this advice is wonderful. And I think, like we established earlier, breast cancer, formidable foe, complex socioeconomic issues, an obesity epidemic, not an easy task. So, I appreciate the work that you do. I think everyone on the Catalysts team is grateful for your work and your service. Thank you for being here.
No, my pleasure.
Great.
Yeah,
Thank you.
Thank you so much.
We hope you enjoyed this episode of The Catalysts, a medical science and discovery podcast by the Schulich School of Medicine and Dentistry at Western University, Canada, bringing you exclusive conversations with leading scientists and researchers.